Good afternoon, everyone, or good morning, depending on where you are, and welcome to a webinar put on jointly by the National Academy for State Health Policy and Mercer on state strategies to support telehealth infrastructure. Just a few logistics before we begin. All of your lines are muted during this webinar. If you would like to ask a question, please feel free to place it in the Q&A function. We will be monitoring it throughout the webinar, and we will have a facilitated Q&A session at the end. And kindly complete the evaluation in the pop-up box after the webinar to help us to continue to improve your experience. With that, I'll hand it over to my colleague, Jody Mance.
Thank you so much, Eliza, and welcome everyone. It's great to have you here on our webinar today discussing state strategies to support telehealth for SUD services. As Eliza said, I'm Jody Mans. I'm the project director on our behavioral health, aging, and disability team at the National Academy for State Health Policy. We're putting today's webinar on in partnership with Mercer, looking at some specific strategies, some data, and some outcome from states. Next slide. So I'd like to introduce our speakers very quickly. We have some great folks lined up for you today. We have Kathy Nichols, who is a senior government behavioral health consultant in Mercer's Government Human Services Consulting practice. We also have Pete Liggett, who is not only a licensed psychologist, but Pete is also a principal and, is a principal and a licensed psychologist with Mercer's Government Human Services Consulting practice as well. So we're very excited to have them join us. Next slide. And then we're going to be hearing from two state leaders from two states that have very different policy landscapes, different backgrounds, but should be able to share some really interesting information about how they've gone about providing these services. First, we're going to hear from Sarah Goldsby, who's the director of the South Carolina Department of Alcohol and Other Drug Abuse Services. And then we're also going to hear from Sarah Dearborn, who's the chief of the Behavioral Health Unit with the Department of Health and Human Services in the Division of Healthcare Financing and Policy in Nevada. Quite a long title there. Sarah works for the State Medicaid Agency. So with that, I'm going to go ahead and get started and pass it right on over to Pete. Pete?
Great, thank you, Jody. It's a pleasure to be here, and I want to thank NASHB for hosting this webinar. My job today is to really focus on the research around the efficacy of telebehavioral health prior to us getting into the policy and operations piece. And let me just say at the outset of the pandemic, policymakers considering telehealth allowances had many concerns about the efficacy of behavioral health being delivered via telehealth. Stakeholders and advocates really pushed for telehealth, indicating access to any services was better than no access at all. And I think that was a position that held by many, but certainly one that brought concerns to policymakers and clinicians. The Medicaid Evidence-Based Decisions Project really took a look at this early on at the behest of Medicaid agencies and began to gather some of this data, looking at some of the research out there. We recognize that the issue of efficacy of this modality is at the back of people's minds when considering its use. And so we want to provide some background on the research that's been done on the use of telehealth for behavioral health interventions. As telebehavioral health has become ubiquitous, research continues to be conducted. So we're seeing real development in some of the evidence here. So what I'm going to present here in the next few slides are papers that were published in 2020, 2021, and 2022. Some of those are meta-analysis that pull from decades of research. Next slide. So children tend to be the highest volume recipients of Medicaid reimbursable services, as we know, and many of the children have many complicated behavioral health conditions. Trauma-related conditions are among our biggest concern, and children are among our most vulnerable, to be sure. And so there's certainly a big concern around the use of telehealth with children, certainly those who are exposed to trauma. This is a 2020 paper from the Journal of Child Abuse and Neglect that recognized the stress of the lockdown and created potential for increases in maltreatment. And then also really pointed at the fact that telehealth improved accessibility and availability of services. However, it did also focus on some of the challenges. Certainly challenges around attention and emotion regulation skills, ability to identify dissociative symptoms by clinicians, available private spaces for those who are in small dwellings, and a reluctance to process trauma in the absence of being in a safe environment. And so the conclusion there was that not all child trauma cases would be appropriate for telemental health. Next slide. So it brings us to the question of, is it effective? And so in terms of the actual provision of services, this particular study looked at 70 trauma-exposed children who received trauma-focused cognitive behavioral therapy via telehealth. There was a 90% completion rate, and 97% of those who completed saw an abatement of symptoms no longer met the criteria for diagnosis. This lent support to the use of TF-CBT via telehealth with outcomes that were comparable to established expected outcomes with office-based services. Next slide. This 2021 study affirmed that what we've heard from clinicians all along in many sectors, that a higher proportion of individuals showed better treatment adherence with telehealth than with in-person. Folks go to their appointments when they have to just turn on a computer versus get into a vehicle and go to their appointment. Next slide. The situation with substance abuse disorders might be a little bit more complex. This 2021 study indicates that individuals with co-occurring anxiety and alcohol use disorders might benefit from additional support, such as mobile interventions. Those with anxiety only or alcohol use disorder only had better adherence to treatment than those who were in the co-occurring group. Next slide. As a psychotherapist who had to transition my work to telehealth, I had significant concerns about the relationship formation in therapy. And I can tell you that my experience was that I was able to form strong alliances and relationships with people that I saw via telehealth. This 2020 study with 115 participants with generalized anxiety disorder were divided into in-person versus telepsychotherapy. And it showed that telehealth modality did not interfere with the building of the therapeutic alliance and actually resulted in a stronger working alliance. Next slide. The World Health Organization's Global Clinical Practice Network has nearly 16,000 members from all over the world. They did a 2020 study with over 2,500 clinicians from that network, 1,200 of whom participated in a telehealth portion of that survey. It addressed clinician experience with the use of telehealth. 90% of those who participated reported starting or increasing their use of telehealth during the period of time that they did the study, which is really during the pandemic. Participants were asked about their training prior to the use of telehealth, and they looked at whether or not they'd received training on technological, ethical, and legal and clinical aspects of telehealth services. Those with the training were much more confident. However, most clinicians reported positive experiences with effectiveness of their work via telehealth and experienced patient satisfaction with the modality. Next slide. The United States Veterans Administration has been a forerunner in the use of telehealth and behavioral health in particular. This 2021 study on effectiveness of telepsychology with veterans is a meta-analysis looking at 27 studies with over 2,600 respondents, 25 with pre and post data evaluating outcomes, and 18 randomized controlled trial designs. The meta-analysis found that telepsychology is similarly effective as face-to-face services. Next slide. In 2020, the Milbank Memorial Fund published a 4.5-page issue brief summarizing the findings of 55 studies addressing telebehavioral health. The issue brief concludes telebehavioral health is as effective as in-person care for common conditions in adults with depression, anxiety, substance use disorders, and post-traumatic stress disorder. Telehealth showed significantly greater improvements for children with attention deficit hyperactivity disorder, with decreases in distress among caregivers. And that telehealth is neither worse than nor harmful in comparison to in-person care for many behavioral health conditions. Next slide. And finally, another meta-analysis in the journal Clinical Psychology Review published last year reviewed 57 empirical studies conducted over the last 20 years. 43 looked at intervention outcomes, 14 examined assessment reliability. They concluded that video conferencing technologies consistently produced treatment effects that were largely equivalent to in-person delivered interventions across 281 individual outcomes and 4,336 clients. Assessments using video conferencing technologies did not lead to differential decisions compared to in-person assessments. Certainly, there's a need for continued continued randomized controlled trial studies on telebehavioral health, among other types of studies looking at client satisfaction. So we want to shift gears now, and I'm going to pass things over to Kathy Nichols, my colleague, who's going to focus more on the policy and operations considerations when using video technologies and behavioral telehealth.
Thanks, Pete. So one of the things after you make the case for telehealth that we've found with our clients and our work is that then we need to look at the landscape to see about the implementation and how to operationalize services. So if we go to the next slide, what we know is that there are advantages to telehealth, and that we're seeing more and more that there is an opportunity for a wider network of providers, more access to specialists, improving out opportunities for both patients and providers to connect with somebody that looks like them, and an increased patient confidence for those typically that are unwilling to seek out in-person behavioral health treatment, perhaps due to stigma or other reasons. But as businesses adapt, and as we've had to adapt, been made to adapt due to the pandemic, workflows, procedures, and business models have been put into place, and now need to kind of have a look back to see how we can better implement this new modality of offering treatment. What we have found to be true across many of across a great deal of our research and across a lot of our clients is that a hybrid model is what is most preferred by both recipients and practitioners, so that there are still in-person options available, as well as telehealth, so that the individual has choice. Next slide, please. So some of the factors that providers have to think about as they're trying to implement a hybrid model is what is true for the community that you serve. What are some of the challenges? What is the impact of telehealth going to be? Do you treat a population that's going to be more or less comfortable with this modality? So that's one of the first things to kind of understand and think about. Challenges that are a part of that operationalization are that the mental health services from healthcare providers and frontline workers, they're longer hours, they're very stressful, can be dangerous due to COVID, but other reasons as well. And there might be other challenges that are unique to the area that is being served, like a lack of broadband, which is still quite common in many areas, or access to equipment. So trying to determine how your services can be accessed by a diverse group of patients with different needs. And then budget, of course, is always important. There's a lot of conversation around rates as part of the implementation of this. They're the same as in-person services. There's not the need for the brick and mortar, but there definitely are other costs associated with implementation of telehealth that need to be considered by states and Medicaid agencies and other insurers. Next slide, please. Other possible expenses besides just the broadband may be the need for a project manager or someone to set up the technology for patients. Some cases that will require hiring an IT specialist. Others will be contracting for technical support. Staff training, as Pete pointed out, and previously, after training, individuals become more comfortable, but there is a cost to that as well for providers to go through training and have cultural sensitivity for both telehealth and in-person services, as well as just how to understand the difference in how to approach somebody virtually versus in person. There's different kinds of telehealth technology to consider, looking at everything from your computers themselves to the broadband to your office space, and then additional telemetry for other things that might be considered, such as pillboxes that have timers and other technology of that nature to assist with engagement. The top priority is to just ensure access to telehealth, which also has the consideration for whether or not insurers are going to cover audio only for areas where there is not available broadband, but interventions are still necessary, care is still necessary. How is it appropriate for somebody to access services virtual via telephonic only? And then there are some places which have chosen to offer telehubs, so rooms where there is a computer and free internet access that are in community centers or libraries, so that individuals can access services in a secure and safe space if they're not able to access services at home. Next slide, please. So we also wanted to touch briefly on marketplace expectations as part of determining that business model. If we go to the next slide, two of the things that providers need to think about are the consumers and the payers. Consumers want choice, and as they are progressing, they want services with real-time online scheduling. They want personalized care, and they want convenience. So part of purchasing a platform and determining how services will be offered is more than just the audio visual connection. What other parts of the package do you want to consider to include? And that goes back to the question of cost as well in developing rates. Payers are going to want to continue to be able to have measurable performance, interoperability and data sharings through an electronic health record or other resource, as well as transparent services and the ability to accept value-based contracts with downside financial risk. So those are considerations on the payer side, but the provider has to balance these expectations as they develop their business plan. Next slide, please. The other thing for consideration, again, beyond just the audio visual face-to-face is the digital storefront, your first impression. First impressions matter. So when you're putting your virtual services together, is there a walk-in ability for immediate sessions? When it is immediately available, it's more likely that the consumer will continue long-term. There are chances that as a consumer is searching for telehealth right this second, doing a Google search, how do you make that right now possible? How do you connect with them? And how do you change your staffing so that maybe there is somebody on call just for those individuals? And how do you make sure there's a warm handoff and engagement? So really thinking through the business intelligence and population health management of the design is important as well. Next slide, please. So finally, I just wanted to finish with a brief discussion on funding options. There are resources out there, but just as the consumers that are being treated need to know what resources are there for them, providers and states need to be aware of the options that are out there to assist them both in their policy planning and to look at some more studies such as Pete had in making policy decisions, but also in connecting to broadband and increasing the access to the individuals that are being served. There is a Telehealth Resource Center grant program that can help with the implementation of cost-effective telehealth programs. HPSA has been providing evidence-based training and support to help providers and especially in rural frontier and underserved populations, and training for helping to treat patients in their communities, coordination with other states. States have come together. For example, the Eastern states have a multi-state council to share best practices, modeling the Western States Pact, which is another regional group looking to share both resources and education and learned opportunities to connecting health issues as a result of COVID. Part of the Western States Pact includes goals on broadband access as well. And then there are public and private partnerships. States and counties are at various stages of implementing the middle mile of trying to connect that broadband service in between and get the provider to the consumer effectively. And then finally, there is a broadband infrastructure program that also can be a source for funding and education and assistance. So these are all opportunities that hopefully folks will be able to take away from here, if you haven't heard of some of these, to seek some additional support and information as you're considering your telehealth policies and the implementation impact and operational impact on providers. So that is the end of our presentation, trying to just set the stage for policy considerations, effectiveness, what we've learned since the pandemic and before, as well as considerations on the other side. You set the policy, now how do you make it happen? So with that, I am going to turn it over to Sarah from South Carolina.
Thanks, Kathy. I think it's a good start. We will share our perspective and a little bit about where South Carolina was in the development of our policy and building our capacity, how we shifted and adapted, and where we are now and where we think we're going in the future. So on the next slide, I just wanted to let you know that, like yours, our publicly funded addiction treatment system is unique. And we have 32 county alcohol and drug authorities that serve all 46 of our counties. We also have 23 private opioid treatment programs in the state that have become our subcontracted service providers only recently. And so with this system, around 43,000 South Carolinians are treated for substance use disorders annually. And despite what you see on this map, our state is mostly rural with only 3 metropolitan areas. On the next slide, I just wanted to talk a little bit about where we were before COVID-19, because I think as a state, we really thought of ourselves as being fairly advanced in our telehealth capacity. And we were actively, trying to advance policy and get our infrastructure further along. We've had the great benefit of having our General Assembly make telehealth a priority. And they established and funded the South Carolina Telehealth Alliance in 2015, which really paved the path. It's, had statewide collaboration of many organizations to develop and advise on the use of that technology. So having that under our belt, we also pursued federal funding, and with an award from the U.S. Department of Agriculture and some of our state funding, we've been supporting our county alcohol and drug treatment sites to get equipped with telehealth carts. And we did that as early as 2015. And with that hardware in place, our state agency has been subsidizing those service providers' broadband costs since 2016. All of this with an aim to really ensure that they were able to connect to our state's telehealth network, with the vision that this would be the infrastructure to do telemedicine for medications to treat opioid use disorder and OBOT services, getting into those rural pockets of the state where we don't find local prescribers. But until 2020, even with all that infrastructure, we didn't have reimbursement for the rehabilitative behavioral health services. We just hadn't gone down that path. There wasn't really a need as we saw it. And so we only had some Medicaid and block grant reimbursement for some telemedicine services. And ahead of the COVID pandemic, our state's Board of Medical Examiners, they had moved a little bit slowly, cautiously. They had really only recently opened up to requiring a petition for the board approval of each individual physician and nurse to engage in medication-assisted treatment practice by telehealth. And so, they were still having to initiate that by way of a telemedicine consult, even after approval, so that a patient was being seen for a history and physical in a medical practice first. And that was something our Board of Medical Examiners felt strongly about. The next slide just shows the technology that we'd invested in, making sure we got telemedicine in our practices, thinking that in-practice consults was the wave of the future. And there's still a place for this, with telemedicine consults in terms of access. But, and you'll see on the next slide that it's not what we needed when the pandemic hit. As soon as we knew isolation measures were going to go into place, in March of 2020, our providers were rapidly transitioning to platforms like Doxy and video to work from home and to maintain those services. So we went to our state Medicaid colleagues to coordinate and align our block grant, our state opioid response grant, and our Medicaid fee-for-service funding, so that our providers and our patients could have consistent reimbursement for teleservices. And I mentioned those 3 funding sources because we are not a Medicaid expansion state. And so our uninsured really rely on our block grant and state opioid response reimbursement. I'm sure, many of you were all having these conversations around that time, the policy discussions, around what are we going to do to make sure that we maintain patient connection, continued engagement, and all of that safety was top of mind because we know that isolation is unfortunately a good friend to addiction and mental disorders. But these were tough conversations, and where some decision makers and the payers really had to overcome the fears of fraud and waste and the fear of never being able to turn off the switch we were hitting. So these were fast decisions, out of necessity. And as you know, it catapulted us all into the future. In South Carolina, we decided to reimburse for the services you see here and a few others by telehealth and telephonically. But we decided against paying for group services, and I'll say more about that in a minute. Recognizing that our patients, also many of our patients really wouldn't have cell phones or enough data or service plan to support the therapeutic services. We also allocated some of our state funds that we had existing to support our providers for them to purchase phones and minutes and data plans for those patients in need. And so we're continuing to use those allocations on an as needed basis for the patients to still access that infrastructure. And then, with our state public health emergency declaration, our board of medical examiners did shift. They issued an order allowing more prescribers to initiate medications for opioid use disorder by telehealth without an inpatient visit first. And this was just buprenorphine. And so this was previously prohibited. And the board's order required our agency to petition the board for prescribers to be approved. And while this was an extra step, the approval process was fast. And we batched the addiction medicine prescribers by health system and organization for those petitions. They were all prescribers that we knew and we trust. So it worked well that the single state authority for addiction services, had that trust by the board of medical examiners, and we could really keep services going with some assurance of quality. Let's see, on the next page, we've all seen the positive results. Kathy and Pete talked about them with, great detail of the studies that have been done. Patients make it to appointments. They have overcome the typical challenges of transportation and childcare when they can connect at home. Our clinical staff have, told us that they're able to get deeper in that clinical sense, one-on-one when they can see the patient's environment. And overall, most patients, are reporting high satisfaction with the teleservices, but we've had some challenges. And for us, I think the top challenge centered on quality and really the quality of group therapy. We didn't approve reimbursement for therapeutic group services by telehealth immediately. Because in our view, this was, at the time we're treating substance use disorder, and that's really a relational experience. So we wanted to be confident that a high quality therapeutic group setting could be cultivated on a virtual platform. And these are concerns that Pete and Kathy noted, concerns about confidentiality, concerns about patient safety. And so most of our providers were pushing us really hard to turn on the reimbursement. But when we sat and observed their groups by telehealth and watched that activity happen, the service wasn't even meeting the definition of group psychotherapy or group counseling. And that's not to say that the group check-in wasn't valuable, but we wanted to be sure we were going to get the therapeutic service that we were agreeing to pay for. And in addition to that, some of our provider organizations, they didn't even want to deliver groups by telehealth, or do groups virtually, believing that virtual environment was going to diminish the quality of the service. So on the next page is a little bit about what we did. We did call other states. We looked for, clinical guidance, and we got some technical assistance to set up training, set up privileging, and an approval process for both clinicians and provider organizations to be reimbursed for telehealth services for those groups. And we had them do a number of things, including update internal policies and procedures specific to telehealth for individual and group therapies. They needed to have a telehealth specific consent form. They needed to have safety plans and protocols that we viewed and approved specific to telehealth service provision, especially for those situations when a therapist believed that a patient might be in danger. And we had them update supervision policies to include telehealth service provision as well. And so, of course, we offered sample policies, we offered, sample consent forms specific for them, and directed them toward the approved trainings. For approval, our staff continue to observe the therapy and observe the counseling to be sure that it's up to a clinical standard. And this was a lot of work, but we really believe that it was helpful to ensure quality. And if we had turned on the reimbursement without some of these processes, we might still be paying for subpar or unsafe care. And really, as a result of some of this, it's been a shift toward more individual services and a movement away from group substance use counseling. And we have a lot of curiosity. While we haven't measured anything, we're curious to know if that's what's driving the patient satisfaction is more individual services, and that could be contributing to better outcomes as well. And so on my last slide, I'll just say, like you all, in a number of ways, we're embracing the new normal. We recognize that there is a greater need for services, and the comfort of continuing teleservices is there. And I really appreciate Mercer's perspective on a hybrid model that we're now all exploring. The reimbursements that we've turned on will continue, but we're thinking about the future with a few things in mind. And like all of you, I'm sure workforce is top of mind. It's a major issue everywhere. For us, the telehealth companies like Talkspace and BetterHelp have scooped up our licensed clinical specialists, pulled them away from the publicly funded substance use and mental health service systems, with salaries and full-time work from home opportunities that I don't know that we can compete with. So I see this as an equity issue, especially for the folks who rely on the public systems and who deserve, that level of care. But how, our questions now are, how do our public systems adapt and modernize in the way that Kathy noted to serve and to compete in that market? We still need to have more conversations with our board of medical examiners. In South Carolina, when orders were rescinded, orders were reversed, and we ended the public health emergency. And so now we're back to where we were with medications for opioid use disorder having to be initiated in person. And we realize the public safety concerns around opening this up, but we do hope to find long-term policy solutions that strike a balance, allowing us and our trusted providers to treat remotely. I think this is going to help us with our ongoing access issues in our rural areas as well. And so finally, but it's certainly not last on our list as we think about the future, and Kathy noted it, I think we've got to keep addressing the barriers that prevent our most vulnerable and disadvantaged populations from accessing telehealth. And this has a lot to do with the technology and the internet connectivity itself, especially in our rural and low-income communities. So even when we paid for the phones and the data plans, some of our patients are really in connectivity deserts in our state. And luckily last year, our General Assembly established the South Carolina State Broadband Office as a central planning body to coordinate the ongoing development to access of that broadband statewide. And with Congress's attention to the issue, we're really hopeful to see more of those federal opportunities to match, the state and local and private investments with the specific attention to those broadband deserts. So overall, I think I'm encouraged, especially hearing the conversations around our state house, the conversations going on in DC, and even this conversation today that are, really all focused on the future and sustaining the services. And so I know we'll have time for questions and answers. My contact information is here if you want to reach out individually. And I'm excited now to turn it over to my colleague, Sarah Dearborn, who's going to share some of the great work going on in Nevada.
Great. Thank you so much, Sarah. I appreciate it. Good morning. And for those of you in the East, good afternoon. My name is Sarah Dearborn, and I'm the chief over our behavioral health unit at Nevada Medicaid. On behalf of Dr. Stephanie Woodard, our senior advisor on behavioral health for the Department of Health and Human Services, I'll be presenting today on some state strategies to support telehealth infrastructure from the Nevada perspective. Next slide. Nevada's vast geography poses many challenges for providing comprehensive substance use disorder treatment services across our state. The majority of Nevada is classified as a health provider shortage area. We have very few healthcare and behavioral health providers in rural and frontier Nevada. Telehealth has been a solution available for many years. However, the utilization of telehealth had been incredibly low until the pandemic. Barriers to uptake in telehealth services have traditionally been things like lack of access to bandwidth, Wi-Fi, and technology to enable connection, providers' concerns about the competency of telehealth service delivery, lack of information on efficacy, and patient technology literacy. Next slide, please. And yet Nevada has had some of the most progressive legislation and policy in place to allow for telehealth utilization broadly for the past several years. In 2015, the Nevada legislature passed Assembly Bill 292, which at the time was one of the more progressive telehealth policies across the US. Assembly Bill 292 described adopting telehealth as good public policy to encourage and facilitate the use of telehealth to improve public health and quality of care while lowering healthcare costs established in our NRS. Some of these were to allow for the boards to issue special purpose licenses to out-of-state providers who want to practice telemedicine only. Also, providers must also provide services in accordance with their scope of practice and meet standards of care. Also requiring Nevada Medicaid and other health insurances to cover telehealth to the same extent as in-person care. And lastly, providers cannot require an established provider relationship, prior authorization if not required for in-person services, or make telehealth a condition of paying for services. Next slide. Following the passage of the state telehealth law, Nevada Medicaid established policy to align with the statute. Since 2018, Nevada Medicaid policy has allowed for payment parity. Prior authorizations must be applied equally to telehealth and in-person services, use of a HIPAA-compliant audiovisual technology platform, synchronous and asynchronous services. Also, providers must use telehealth within their scope of practice. In addition, since the Medicaid policy was put in place, the Division of Public and Behavioral Health has had payment parity for grant-funded substance use disorder treatment providers for telehealth and continues to align with Nevada Medicaid policy. Next slide. So following the declaration of the public health emergency, quite a bit of support has occurred to support the use of telehealth across our state. Governor Sisolak enacted Directive 11, which allowed licensed providers in good standing to register with occupational licensing boards in Nevada, which enabled broad telehealth access for behavioral health services. Also, federal block grant subawardees were allowed the flexibility to purchase telehealth equipment to allow for rapid uptake of telehealth services, and provided opportunities through the Addiction Technology Transfer Center network for provider education. Also, technical assistance was offered to ensure grant-funded providers had policies and procedures to deliver telehealth services safely and effectively. We also allowed for the utilization of telehealth services for residential treatment to allow for COVID mitigation and cohorting of patients. There was also information dissemination through provider portals and web announcements for telehealth policy from our Nevada Medicaid agency. Nevada Medicaid also allowed for inclusion of audio-only services, and grant-funded providers were offered the same flexibilities in order to align with CMS. Also, expansion of allowances of telehealth for some services that were previously restricted, like psychosocial rehab for youth. We saw that as a growing need throughout the beginning of the pandemic. Considering services being delivered through telehealth was crucial. Telehealth prescribing for medication-assisted treatment was also encouraged to reduce patient access to care issues and allow for that continuity of care for patients in our rural areas. Next slide. Prior to the pandemic, only 3% of the Medicaid beneficiaries were receiving behavioral health through telehealth. Following the initiation of the public health emergency, 25% of Medicaid beneficiaries were receiving behavioral health through telehealth. The trend continues with 21% receiving services via telehealth this past year. We're continuing to refine our data collection with our data analytics team to be able to drill down the specifics to support how we implement effective policy change to support the needs in our communities. We'd like to look more at the rates of telehealth use between things like age ranges, ethnicities, and regions within our state. Also, when surveyed, 90% of grant-funded substance use disorder treatment providers indicated they expected to have telehealth as part of their core service array going forward. Most providers indicated a preference for a hybrid model of care to be able to adapt to the patient needs and reduce barriers for access to care. Many providers reported steep drops in no-call, no-show appointments, greater provider satisfaction, and greater patient engagement. Next slide. During the 2021 legislative session, Senate Bill 5 was passed, removing prohibition within statute for audio-only telehealth, while allowing Medicaid flexibility in policy and payment. This bill also required the department to create a data dashboard, which, as we know, is a critical piece to understanding the efficacy of this service delivery. Currently, Nevada Medicaid is working to align state plan and Medicaid service manual policies with Senate Bill 5 by removing restrictions around audio only, as well as aligning payment parity across audio only, audio visual, and in-person services. We're hoping these new additions will align with the end of the public health emergency, which currently has allowed for these restrictions to be lifted. So when ended, policy will allow for continuous coverage of this service delivery. Next slide. Medical necessity is at the core of the debate around the utilization of telehealth services for substance use disorder treatment. Medical necessity must be established for the provision of telehealth services and is considered the foundation for clinical decision-making. Briefly defined, medical necessity applies to a healthcare service or product that is provided for under the Medicaid state plan and is necessary and consistent with generally accepted professional standards to diagnose, treat, and prevent illness or disease, regain functional capacity, or reduce or ameliorate effects of an illness, injury, or disability. Next slide. Determination of medical necessity walks providers through considerations for things like type, frequency, extent, and duration of treatment, level of service that can be safely and effectively furnished, services that are delivered in a setting that is clinically appropriate, and also services are provided for medical or mental and behavioral health reasons. When applying medical necessity criteria, providers must determine if the service can be provided via telehealth safely and effectively, and that the service is clinically appropriate for the patient. This empowers the provider to determine, based on their scope of practice and competencies, if the use of telehealth is appropriate for the client. Next slide. There are many issues that tend to arise when discussion of telehealth occurs. As telehealth policy evolves and the evidence base grows, we anticipate more rigorous discussion about the use of telehealth and the cautions for ethical considerations. Also, understanding the data to support these considerations is critical. These considerations include things like equity issues and access to broadband and Wi-Fi, digital literacy, informed consent, the patient-provider relationship, offering patient choice, lessening the impact of barriers to care, things like transportation, childcare, and leave time, managing high-risk patients, in-home medication-assisted treatment induction, levels of care appropriate for telehealth and implications for programming, incentivizing continuity of care, and lastly, emerging technologies for asynchronous telehealth and remote patient monitoring. Thank you so much. That concludes my presentation piece, and I know there's time for questions. Thank you.
Perfect. Thank you so much to all our panelists. Lots of great things happening across states and lots of good data that we started out with. So the first question that I have here, I think is probably goes back to Pete and Kathy's presentation. Is there any evidence about the effectiveness of audio-only telemedicine visits compared to audio-visual visits?
Yeah, so Jody, the many of the surveys that are done of sort of the research articles over time don't focus on the difference between video conferencing and audio only. There are, though, some research studies around audio only relative to psychotherapy that show that that outcomes are good with psychotherapy, in particular if there's already an established relationship. Certainly, there are research articles out there that show that there is a positive impact of psychotherapy through audio only compared to a person receiving no services at all. There's ample evidence out there showing the efficacy of audio only services for crisis intervention. You know, we've had crisis hotlines since the middle of the last century, and there's been a lot of research around the efficacy of audio only intervention for crisis services. Certainly, there's a lot more that could be done to look at the differences between teleconferencing versus audio only, and I think that's probably an area that's going to grow. I think one of the slides that I had focused on teleconferencing generally, and that was a survey or a meta-analysis of articles that use teleconferencing, not audio only. But there is indications that it is effective. I think that the details on that are really developing.
Thanks, Pete. That's helpful. To move along to some state questions. Sarah Dearborn, one of the things, oh, I'm sorry, I think I see one more. For Sarah Dearborn, one of the things that was on your list of considerations was provision of in-home buprenorphine induction. Can you talk a little bit more about how your state is considering doing that and how providers are thinking about that?
Sure. I think in collaboration with our Division of Public and Behavioral Health, as well as our certifying agencies that oversee our substance use treatment programs, it's just really crucial to come together, us being Nevada Medicaid, as well as those divisions, really to understand some of those barriers, some of the impacts of allowing for that. But I think it also really goes back to the medical necessity piece, as well as the clinical appropriateness based on the individual, and if that's really an appropriate form of service for those individuals.
Mm-hmm. That's helpful. Thanks, Sarah. For Sarah Goldsby, our two Sarahs on today, can you talk a little bit more about some of the workforce challenges and how you might be addressing those across state agencies, particularly with workforce boards or workforce stakeholders around working with emerging providers to help support their entree into public health, public behavioral health, and how training for telehealth provision of services might be changing?
Sure. So I'm sure, like most states, we're all thinking about pipeline retention, especially with the behavioral health workforce. And so, you know, we're looking at other states, what other states are doing. I know Tennessee has a really robust task force looking at this issue. Internal to South Carolina, not only are we looking at other states, but we're working with our certification boards and our licensing boards to look at any of the barriers that we've imposed with policy unintentionally that might be driving folks away from joining our workforce, whether that's cost. and certainly with a mind to, we don't want to, diminish the credentials and the quality of the provider's aptitude, but can we bring folks in and make sure we're not pushing them away unintentionally just with our processes, our certification processes, our licensing processes. So taking a close look at that. And in terms of an untapped workforce where we're trying to build, we have been certifying certified peer support specialists in our state for the last few years and focusing a lot of that work with our inmates in our Department of Correction, folks who might be staying, but a lot of folks who will be leaving and coming back to the community, getting their certification before they leave. And now we're looking to develop an even more robust certification program for them to become, they're still termed substance abuse counselors in our state. We wish we could get away from the term abuse, but get them on the path to a counseling credentialing. And knowing that the peer support workforce we've built is probably and hopefully the next generation of counselors for our state, and building that pathway for them.
Mm-hmm. And it's interesting, Sarah, that you bring up peers, because one of the things that we hear from states often is that peers have been providing kind of de facto telehealth supports for quite a long time. So in the context of this conversation, there's a lot to be thinking about in terms of reimbursement and rates and what those relationships should look like. So thank you. This question really, I think, has a research background, but I would certainly open it up to our two state folks as well. In terms of outcomes, what has research told us about telehealth for stimulant use disorders and polysubstance use disorders as we continue to see data that indicates that those disorders are increasing?
So I will have to defer to Sarah or some of the other panelists on that specific question, because I'm not clear on the specifics of stimulant use disorders.
Jody, I don't know that we can speak to, telehealth's impact on individuals with those particular disorders. Unfortunately, there is not even a real gold standard of care for stimulant use disorder other than contingency management, which I think still has a lot of exploration to be done in terms of how much, for who, when. We know that it works, but I think the research is needed on how we integrate contingency management with the touch points of the clinical care, using the hybrid telehealth model that I think we're working on in the future.
I would agree. It feels like another one of those planes that we're building as we're flying it, right? Another question that I think is this is probably more aimed for our state folks. But as states start receiving opioid settlement dollars from some of the legal settlements with pharmaceutical companies and other tangential players in the opioid epidemic, how do you see those dollars being able to support telehealth infrastructure and telehealth policy in your states?
Go ahead, Sarah Dearborn.
Thank you. It was who's going to get off mute first on that one. So for Nevada's perspective, I think it really also goes back to, honestly, Senate Bill 5 that was just passed, and really understanding the data based on the services that have been provided throughout the pandemic, and really kind of figuring out and considering what direction can we move in with those dollars coming in for Nevada. I think just initially trying to understand the data, there's going to be quite a bit, but also understanding how to even request the data is important as well, to really get to a point where we can be successful in utilizing those monies.
And just to build on that, I think with, there's a lot of opportunity with that funding, knowing that it's got to be supporting the strategies to abate the opioid epidemic. That includes a number of things, and not only service delivery, but research as well. And some of that can be tailored. What's special about those funds is they can be tailored to unique state needs and unique municipality and unique county needs. And so it can really, support the unique facets of what's needed geographically.
I appreciate that both of those responses were very cognizant of the need for research and data support and being good stewards of those dollars and figuring out how they can best support you in your states. I do have one final question for our states, but I want to just do one last call to see if there's any other questions from our audience that are in our Q&A. All right, I've waited the obligatory number of seconds. So we can move to kind of a last thought question for states that maybe are in a different place in terms of what they've built up for telehealth supports, maybe don't have the kind of legislation and legislative infrastructure that Nevada has, or haven't had the kind of provider engagement that South Carolina has. What kinds of advice would you give to other state leaders in your positions, whether in state Medicaid agencies or behavioral health agencies, as they're having conversations with their legislatures, their stakeholders, and their providers in order to develop this kind of infrastructure?
This is Sarah Dearborn. I'll go first and then turn it over to Sarah. I think from the perspective of Nevada Medicaid, it's been incredible to have a working collaborative relationship with across our divisions that specialize in behavioral health. Not always do we have the clinical backgrounds to support at Nevada Medicaid, so really relying on our partners at Division of Public and Behavioral Health, as well as our certifying substance use agencies, is really a crucial component to kind of bringing the whole state forward on implementing successful policy.
Yeah, I agree wholly with Nevada and the collaboration internal of the state. I think two other points I'd make, and they're going to sound trite or like they're canned, but they're not, I promise. I think for us, keeping the patient, right, the frontline care, the service, the person who we're trying to serve at top of mind in making these decisions. Otherwise, what are we doing? And then there's just the benefit of learning from other states and reaching out to colleagues in other states. That a lot of states are more advanced even than we are. And we reached out to Nevada in the midst of the scramble, setting up our infrastructure, knowing that they were a little more advanced. And I think that's, the beauty of what NASHB, Mercer, NASVID, that's what we do. And that state to state sharing and learning is just invaluable.
Yeah, thank you. There have been some great thoughts today. We are right here at the end of our time together, but really, really helpful insight, some great research and background from Kathy and Pete. So thank you so much to Mercer. And of course, thank you to both Sarah Goldsby and Sarah Dearborn for sharing the experiences of your states. Eliza, I'm going to kick it back to you to wrap up.
Thank you, Jody, and thank you to all of our participants who tuned in today. Please be sure to complete the post-webinar evaluation. It will pop up when you exit out of this screen. Thank you again. Thank you to all of our speakers, and have a lovely rest of your day.